Thanks very much, Ron, for those comments. And now, Joanne, we'll move on to you.
This has been a really informative morning, so thank you very much for inviting me. I'm coming from the cohort research realm. I'm with the Framingham Heart Study, which is a community-based observational study. It started in 1948, and we're currently following 6 cohorts of participants, not patients. About 10% of our participants are multi-ethnic, and a small number of those speak a language other than English. They're all undergoing follow-up, so we have an opportunity to bring them back and see them prospectively. Our participants get routine test results after a research exam. Their research exams are about 4 hours, so there's lots of testing done. And we, as a study, have had educational efforts through the consent form and participant newsletters to educate participants about the limitations of research findings compared with clinical care, and to emphasize that we are not their care providers, we're researchers. So the routine results that we might provide shortly after a research exam would be by mailed report and would go out to the participant as well as their healthcare provider, and might be as simple as cholesterol results, glucose, kidney and liver function results, blood pressure, a routine electrocardiogram. So we report biospecimen results as well as non-laboratory results. And the results that go to the healthcare provider actually ask the healthcare provider to put those results in context for the participant or their patient. So that removes the researcher from providing healthcare. Over time, as you can imagine, from 1948 to present, the assays that can be provided on these lab specimens have become much more specialized and novel. And we ask that the PI actually make determinations of what should be reported back to the participants and healthcare providers. And we use an analytic framework similar to what's been reported from the Bookman report and Rich Fabsit's report. So is the return of result consistent with our consent form? And we have, our consent form provides for individual results reporting. Is the measurement accurate? And we've heard a lot about CLIA here this morning. Is the result consistent with a serious health condition? And is there a therapy or preventative intervention for the condition? If the PI determines that all of those conditions actually are met, then the evidence is reviewed by the Framingham Heart Study Executive Committee along with several oversight bodies, including our IRB. We have an observational monitoring board, and we actually have an ethics advisory board, and that ethics advisory board for our study has several key participants, including participants from all of our cohorts, local physicians, key community leaders, a genetics counselor, and a medical ethicist. So we get a lot of input, our study investigators, on what results should be returned to our participants. And for genetic results, we actually have a separate committee, which is multidisciplinary, to look at what genetic results we might consider returning to participants. We've actually engaged outside experts to look at that as well. And because of this CLIA issue, which hasn't been as clear at our institution, we've actually engaged legal counsel at our institution, who actually reached out to legal counsel at other institutions, and Ropes and Gray in Boston. And we've worked with other cohort studies to decide what might rise to medical actionability. When we do return results, we actually train staff and physicians on specific scripts if we're going to actually call participants. We might make a phone call first and then follow up with actual written materials. In terms of what we might provide to physicians who might be uncomfortable with results, we might actually consider result-specific informational packets, which can be sent specifically to the participant and with the participant's consent to their designated healthcare provider. So we have had these processes in place over time and have had the opportunity to refine them. In terms of community engagement, as I said, we have the Ethics Advisory Board, which includes participants. We have a study website. We have annual newsletters that go out to inform participants about study-specific results. And we have actually surveyed our participants regarding what results that we have sent out. In terms of medical follow-up and decision-making, we remove ourselves. We're researchers. We are not healthcare providers for our participants. We ask that the participant make any healthcare decisions regarding routine or other research results with their healthcare provider. And we do have potential opportunities to reevaluate results and medical actionability over time because we're following our participants longitudinally. And I guess I'll stop there.